program. And my name is Sunil Sharma. I'm currently working at Ruby Memorial. I'm Division Chief for Pulmonary Critical Care and Sleep Medicine here at West Virginia University. And it's a pleasure for me to today talk about what we have been doing locally in the Appalachia as far as sleep research is going on. So next slide, please. So just a conflict of interest, I had speaking engagements with Zoll Respicardia. I have some grant funding to do research in pulmonary embolism and the REST trial. And I am a co-inventor for a patent for artificial intelligence to screen for OSA. But none of this pertains to today's talks. Next one. So I wanted to kind of get a sense from the crowd. So what I wanted to do was bring these two questions to set the stage for it. And I wanted to know with a show of hands or type it in, which state do you think is the most sleep-deprived state in our country, US? So first choice is California, then New York, Florida, West Virginia. Which one takes the honor to be the most sleep deprived? Florida. There you go. New York. Wonderful. California. Okay. That is great. So, and this is exactly why I am intrigued with, because I go worldwide and ask the same question and I get the same answers. And it's actually West Virginia. We are the most sleep deprived state in the entire country. So the second question goes is, which is the most heaviest state in the country? Is it Texas, West Virginia, Rhode Island, North Carolina? All right, somebody got the right answer. It is West Virginia. So the answer to both these questions actually is West Virginia, and that's why we're talking about this. Next slide, please. Next slide. So it should be Sleepless in, next slide. Appalachia. That's how it should be. So I think that this movie is not done justice to the country because it took the title away from us and took the attention, but actually the movie should have been labeled in Appalachia. So why are we talking about this? Well, the thing is that sleep is so pervasive and it is absolutely involved in every physiological, pathological processes in our body. And if you don't get enough sleep or you're getting bad sleep, it will have huge implications on all other comorbidities which you treat on a daily basis, be it diabetes, be it hypertension, congestive heart failure, atrial fibrillation, stroke. So if this is the root cause and the thread which combines all of these comorbidities, why are we not tackling that? So that's the main basis of our research, the main basis of what I'm going to be talking today is to how we're creating either awareness or tackling this issue. Next slide, please. So how do we know, first of all, why are we the most sleep-deprived state in the country? The way we know that is that CDC conducts a survey every year, and the definition of sleep deprivation based on CDC criteria is 7 hours or less. If you're getting 7 hours or less of sleep on an average, then that you consider sleep deprived. So they send out surveys randomly to every state, and consistently West Virginia scores the highest, which is about around 42% of the population surveyed say they sleep less than 7 hours. So that's how we know. Next slide, please. And I think this is not a surprise to any one of us that several surveys on obesity have brought, West Virginia has been touted as the heaviest state. It often competes with Mississippi every year for this title. And the reason for why I bring this overweight thing is because this is the #1 risk factor for obstructive sleep apnea. So the higher the obesity, the more the obstructive sleep apnea. So the corollary is if you have a state which is the highest obesity, it most likely also has the highest obstructive sleep apnea. Next slide, please. So in essence, basically our biggest problems in our state of West Virginia, which is impacting care for any chronic diseases, is one, sleep disorder breathing, and the other, sleep deprivation. Okay. Next slide, please. So this is our study, which we first did as to say, we're going to look at our healthcare database, mostly Medicaid, in West Virginia, and see where does sleep apnea get diagnosed? How many people are even diagnosed with sleep apnea? What's the extent of problem? So I marked it out in blue. It's our overall diagnosis based on Medicare database of 500,000 people who were in that database was 8.8%. Now, the national average or overall prevalence of sleep disorder breathing is 25%. 25% patients of obese baseline have sleep disorder breathing. So we are not diagnosing. It is a severely underdiagnosed, underrecognized condition this far in West Virginia, and of course contributing to various abnormal baseline conditions which we are seeing as far as atrial fibrillation, heart failure, and stroke. Next slide, please. So sleep deprivation was the other issue we were talking about. And this is not alien to humanity. If you look at the data from over 100 years ago, as you go down over the century, as a humanity, we used to sleep about 9 hours in the early 19th century. And over the century, our average sleep has gone down to 6.8. So that's something which we have to acknowledge. It just seems like West Virginia seems to be even much more sleep deprived than anybody else. And sleep deprivation, irrespective whether you had sleep apnea or not, has its own devastating consequences, from weakened immunity to risk of chronic diseases, hormonal imbalance, low energy levels. And all of this has been published many times over the last several decades. Next slide. So essentially, we are in West Virginia dealing with this two-headed monster. So why do research on everything when these things is sticking out and saying, this is your main problem? Why are you looking even elsewhere at all? Next slide, please. So we started, how can we tackle this? Considering all the constraints of the finance, of how do you get grants, how do you even get attention of the people? So we decided to do something very unique. We decided to start with a hospital sleep medicine. And you're going to wonder, well, this is a chronic condition. Why are you focusing on the hospital part of it? So next slide, please. And the reasoning was this very nice publication by University of Pennsylvania over a decade ago, where they very smartly started noticing trends across the country, that people who are of low socioeconomic status and also of rural, they now had started preferring hospital to ambulatory care. Okay. It could be multiple reasons, and it's a big topic, and they've sorted it out why this happens. But the big theme was people feel there are too many hoops to be played in this ambulatory game. If I got a problem, just go to the emergency room, get hospitalized, get fixed, and be out of it. So we created a system which does not favor lower socioeconomic or rural people in the outpatient arena, and they are in hordes taken taken care in the hospital. This may not be alien to you in rural hospital, that they will not see a doctor unless it's absolutely needed. And if they get sick, really sick, they just go to the hospital and they don't see outpatient primary care physician. So we decided to piggyback on that if worst of the worst patients are actually coming to the hospital, that is the first contact with the medical professional some of these people would have. Then why not start there with the sickest of the sick than to try to chase them at home? Next one. please. And then we came with this radical concept of intercepting the disease in the hospital. Okay, and we published a lot of things. We don't have time today for doing that, but we over 80 or 90 articles have been published in this regard, in which we showed to the community that if we were to capture this disease while they're in the hospital and then connect the dots, they're much likelier to get better and much more likelier to follow up with the disease. Next slide, please. So there was this concept, which was the USPSTF, which is the United States task force for screening, which had said the evidence suggests that the community, the level of sleep apnea isn't high enough that you should go for screening. And we said, you're right, because most of the sick people who have sleep apnea and are devastating, they get into the hospital. So why are we screening in the community when the yield is so high in the hospital? And we did some studies, and we found out, not just our studies, but there were several published in Chicago and elsewhere, where they showed that almost 60 to 70% patients admitted to the hospital under medical services have an underlying sleep disorder breathing, which has not been diagnosed. So with that higher yield, okay, we think that is where the patient should be screened, not in the community. Next slide, please. So in a nutshell, there were significant advantages that we saw of screening and bringing sleep medicine within the context of a hospital, which is one, intercepting the disease instead of waiting for it. Generally what happens in the community, the way sleep disorders is found out is the wife gets just sick and tired of the guy snoring and getting the elbow treatment all night, and he'll drag the husband and say, do something and fix it. And that may take many, many years. And they may not even know the connection that is probably causing heart failure, hypertension and atrial fibrillation and all of this stuff. So why not intercept it while the patient is admitted for the comorbid conditions? Obviously, it targets the most vulnerable. These are the most sickest people who are, had no other choice but to get admitted to the hospital. So something devastating was happening to them anyway. And hospitals are, in many situations, like the inner city, the rural area, especially like West Virginia, maybe the first contact with the healthcare. So this is a good opportunity to interact with them. And in my own personal opinion, they are a very captive audience. People get admitted for 2 days, 3 days for COPD exacerbation. That we have 3 days of constantly making sure that they're educated what the connection between the two is, as opposed to 15 minutes to 20 odd minutes you get in an outpatient setting. So I think the exposure element is sometimes underappreciated in many of these hospitalized patients. And I think it eliminates bias. For example, what is bias? So the bias in sleep medicine is, if you go in an outpatient setting and then you look riggedy-taggedy, you don't look too rich, the bias with the physician is he's too poor to even consider sleep. Let's just focus on his stroke and atrial fibrillation and forget sleep. That's been shown across the country in many, many studies. It's just is a subconscious bias that, let's just do the more important things. He's not going to do it anyway. But when you come to the hospital and there's a scheduled screening program and is based on certain factors, which you have AFib, heart failure, snoring, stop bang, everybody is getting captured in that. Okay, so we think that, and we have shown that, by the way, again, there's not much enough time to bring that study up, but we have shown elimination of bias in this population. Next slide, please. So this is the setting I wanted to kind of create a little bit of context to the study. The question was that, okay, fine, all of these things sound good, they look good, but show me the proof. Where's the money? Show me the money. So this is the biggest trial we have done, which is a real world study. When we formed our hospital sleep medicine service and we said, Okay, let's see if all of these theoretical concepts which we had talked about made sense. Do they correlate down in the real world? Next slide, please. So here's the study design. In the context of a formal program, which we created at Ruby Hospital in West Virginia, we included everybody. There was a registry where everybody who was seen, interacted, and screened for sleep disorder breathing was included in the study. Over 2,000 patients were assessed in a consecutive fashion in medical, so fairly large number. Everybody underwent a sleep evaluation, and we identified 786 patients who were very high risk that we thought had sleep disorder breathing by either doing a screening pulse ox or doing an apnea link testing within the context of hospitalization. Out of these patients, we think they were so high that we sent them for outpatient gold standard polysomnography. And then after polysomnography were done, they were offered treatment for that. And you can see everybody got treatment, but half of them or less than half of them were adherent, which means that they continued to use their CPAP machine for a whole year, while others were non-adherent. So they became kind of the control group in this group. So let's see what happens with them. So after that many, a couple of years' time, and this kind of gives you a profile of how our patients, 2,000 patients which he selected, look like. Look how severe they are. Look how many comorbid conditions they are. 50%, over 60% have hypertension. Almost 40% have heart failure. Another 28% had atrial fibrillation. Almost 32% had COPD. So this is the sickest of the sickest crowd that you can take into your study. The very essence of the most vulnerable patient crowd that you can get. Next slide, please. And what we were looking for is the cumulative endpoint. And the cumulative endpoint was if you are that sick and if you're not taking care of your basic drivers of that sickness, you will get either readmitted to the hospital or you will utilize emergency room services more. And this is, first one, please. Thank you. So this is a cumulative between readmission and emergency medicine. And you can see there was significant difference between the two. And the patients who were non-compliant were having much more higher readmissions. So sleep disorder breathing, given a CPAP, but not utilizing it, is equivalent to having a sleep disorder, but not being treated. And that's how we looked at it. And these patients have much more higher readmissions to the hospital and much more higher emergency room visit. If we split it, and you can go to the next one, a large part of it was driven by emergency room visit. Look at the amount of emergency room utilization in these patients with sleep disorder breathing and untreated sleep apnea. And by the way, these are only visits for cardiovascular reasons. We did not increase, you fell down from a bike and scraped your skin. Those were not included in that. These are purely cardiovascular reasons for readmissions or ED. Next slide, please. And then we said, okay, if there is increased readmission, increased emergency room, shouldn't it correlate with increased cost of taking care of these patients? And that's basically the taxpayers' money. That's basically the amount of money we'd spend on healthcare. And so what we did was we took the entire data set and we sent it out to our financial office and then say, you guys do this best. Figure out and tell us what was the economics behind this. And what they did basically with this database was they divided it between hospital billing and professional billing. For those who are not familiar with that, hospital billing is the DRG billing, where the hospital patients get admitted and everything which went in and taken care of the patient is the hospital billing. Professional billing, on the other hand, is what the doctors charge as an outpatient if they have a visit or if they were consulted in a hospital. And you can see between the adherent and the non-adherent patient, significant difference in the cost. Patients who had sleep disorder breathing, not on CPAP, were utilizing and much more services and were much more costlier to the system and the hospital and the community, both from hospital as well outpatient needs of these patients. Next slide. And this is a Cox model of breaking it down. And you can see that the mean cost of just one person was for $1,500 more in the hospital side, and a total mean cost of $1,700. So imagine now multiplying this with hundreds and thousands of patients across the state. We are losing millions and millions of dollars on this disease in these patients. Next slide, please. So based not only on this, but on several dozens and dozens of studies done across the country, and the realization in the consciousness of the medical community that this is something we need to look in, the American Academy of Sleep Medicine established and commissioned a guidelines and a task force in 2020. And basically they said, we need to look at all the evidence on this hospital sleep medicine and see where we are across. What do we find it? Because at that time, hospital sleep medicine was not the standard of care, is still not the standard of care, but this is a concept which we had generated. And luckily, some of the leaders, thought leaders in the country thought this was a concept which is worth exploring, and a task force has been formed. And I'll talk a little bit more about the findings of that task force later in this lecture. In fact, I included this right. So last week, the task force came back with the recommendations, and these will be published in the next couple of months period of time. And they did one good practice statement, and they gave 3 recommendations. The good practice statement was that all patients with established diagnosis of sleep disorder breathing on active therapy, existing treatment should continue rather than withheld. So we had found through that task force research that many patients who are even diagnosed as an outpatient, when they admitted to the hospital, nobody asked them whether they have that diagnosis. Nobody puts them on that treatment, and that causing devastating consequences to these patients. So that was a good practice statement, which obviously we need to follow. But here's the meat of it, the recommendation. Look at the recommendation. For the medical hospitalized adults at risk for sleep disorder breathing, the American Academy of Sleep Medicine suggests in-hospital screening for OSA. Something a decade ago, which we had said is important, you should be looking forward for, and we are the ones who started that. We are the ones who created the databases for that. And so we are kind of proud that what we did in West Virginia resonated at a national level. And the ASM is coming back with some very, very specific, strong recommendations on that. The second recommendation is that ASM suggests that sleep medicine consultation be available as part of an evaluation and management pathway in a hospitalized setting. And the third recommendation that came in was that ASM suggests that discharge management plan to ensure timely diagnosis and effective management of sleep disorder breathing should be considered, which basically means that don't just treat the patient in the hospital. If you found that problem, if that's the one which is driving the whole process, make sure that there's a connection to the outpatient and these patients are not lost to the system. Next slide, please. But I think some of you with keen eyes must have noticed in my first study, which I presented, that of the 2,000 patients, high-risk patients were 786. We recommended them to get a PSG, but out of the 786, only 341 actually reached the sleep lab. So the logical question to us was, what happened to the rest? Where did they go? Why didn't they show up at the sleep lab when we had told them This is a high risk for them. So we launched another study and saying, hey, what happens to these patients? What are the conditions which prevented them to get a PSG and a treatment? Next slide. Next slide. So what we did basically was, how do we even look into this? And we looked at a tool called ARGIS GIS, which is basically a geographical information system. Think of it as Google Maps on steroids. What it basically does is that it takes all the government available information on certain health conditions and certain criteria and maps it out throughout West Virginia. And then we take that map and superimpose our patients on top of that. What we are basically looking at is that, are there individual versus community level issues which are preventing them to get these services? So what are the things which we looked at? What are the things available in this, ARGIS online? Of course, we have information on their demographic, age, BMI, race. If they are too old, 90-year-old, maybe they don't have a ride. Maybe they're just too old to travel back to a sleep lab. Same is true for BMI. Maybe they are 400, 500 pounders, and it's just not physically possible for them to get help. What about health literacy score? What about their educational background as regard to their medical condition? What about rurality? Maybe they're so rural, they're so distant that they just don't have that infrastructure to manage and connect the dots once they're discharged from the hospital. What about economic distress communities? They're just so poor that when they came in, even a $20 ride for a sleep center may be too much. Maybe a $20 copay for the sleep study may be too much. What about travel time? The more you travel, the more likely you are that you may not be able to come back. So these are all the things we mapped out. Next slide, please. And this is the publication which we found out what are the factors which are impacting sleep center no-show rate once they get discharged from the hospital and has been identified as having sleep disorder. So we geospatially coded all of these factors. Next slide, please. So this color mapping, heat map, I'll walk you through that, is the lighter areas, if you see, are the ones who had extremely high compliance. The green dot, which you see on the top, right at that Mason-Dixon line, is the sleep center. And you can see the lighter parts are the ones who had higher compliance. And as you get darker, red and brown, they are the ones who didn't show up. So if you look at it very cursorily, it looks like the more further they are from the sleep lab, the less likelihood that they will come back to the sleep center. So we did some statistical analysis. Next slide, please. And we did find that for every 10 miles that you are away from the sleep center, there's 6% chance that you will less likely to come and show. So for every 10 miles, your odds for getting to the sleep lab became less and less. But as we dug further, we knew that there were some other truths that were being uncovered in that situation. Next slide, please. So if you look at this heat map very carefully, you'll realize that the patients who had very high compliance are the ones in the pink. And then there are dark blue, which is the number 2 way of having high compliance. And then you start seeing that these are spread much more wider across the state. And then you see some circles around the lighter areas, which are very poor in their compliance. And yet they are not far, because you can see the dark and the light just next to each other. Why is one area coming up and getting sleep studies and being compliant, in the other area and right next to it is not doing it? And what is it? And we found out that the reason why that is because that's the group which had the lowest health literacy scores. Next slide, please. So in statistical analysis, we found that health literacy score was the most potent factor for them not to coming up back to the sleep lab. And distance, while it was important, was only second importance to health literacy score. Why is that important? Because these are very actionable items. When we know the crux of the reason why they're not coming back, then we can direct our limited resources to target those actionable items. For example, if we found nothing but the distance, then the answer to that would be, hey, we should have more sleep labs closer to these people, and they can do that. But when we have a very strong signal that health literacy surpasses statistically even the drive distance, even the longer distance is the health literacy, then we want to put that health resource in saying, hey, can we educate these patients more? Okay. There's several studies across the country which have shown that physicians overestimate the healthcare literacy of a patient, which means that they're not able to get down to that level and explain to the patient how this is connected to their health, what the next steps are, and how do you accomplish that, and how is that going to benefit them in their own understandable framework. That is the biggest problem. So what we decide is that and health literacy is a low-hanging fruit. You don't have to put too much resources into it. So the people now coming to the hospital, instead of just telling them, hey, you have this problem and you need a sleep study, what we have an educational session for each one of those patients, which we tie these diagnoses of sleep disorder breathing to the underlying cause, which these people were admitted, and we show them why this would help them. Okay. So that's how we use this data to improve the community's health. Next slide, please. And we decided and we found out that we're not alone, that health literacy is a problem which has been identified by national healthcare leaders. In fact, U.S. Department of Health and Human Services has placed health literacy as the #1 target, which will have the maximum bang for the buck. And they started a program called Healthy People 2030, which said if we can increase the health literacy of people by 2030, a lot of these abnormal costs associated by chasing these chronic diseases can be lowered down. So something to keep in mind, I would encourage you to go back and read the Healthy People 2030 set of guidelines, which the U.S. Department of Health Services has issued. Next slide, please. Now, this next topic is not alien to any one of us. If we have worked in a hospital setting, we have noticed that a lot of people get admitted to the hospital for hypercapnic respiratory failure. Their CO2 just keeps on going on higher and higher till they lose consciousness or they become too difficult to breathe for them and they get admitted to the hospital. Very chronic, recurrent problem. And we wanted to see what we can do based on this existing model, which I just explained to you. Next slide, please. So the risk factors for patients with hypercapnic respiratory failure and readmissions, #1 is COPD. And by the way, West Virginia is also #1 in COPD diagnosis throughout the country. Obesity, hyperventilation, and neuromuscular disease. So first of all, we wanted to know who are the people in our state proportionately who are affected. Is it mostly COPD? Is it obesity, hyperventilation? Or is it neuromuscular? Maybe it's all three, but we don't know what proportion each three is. So the next study, which we did, was basically looking at that. Next one, please. And this has already been published, so we'll go to the next slide, please. So in this study, what we did was we again took that entire cohort from our 2,000 patients, and we said how many patients of these were actually admitted for hypercapnic respiratory failure and required non-invasive ventilation for their treatment. And we identified 109 patients out of this cohort we thought would need non-invasive ventilation to prevent this kind of hypercapnic respiratory failure, out of which 47% had obesity hyperventilation syndrome, at least the way we thought where that hypercapnia came from. and 45% had COPD. And only 8% had other respiratory illnesses. So in essence, in West Virginia, half of the patients who get admitted for hypercapnic respiratory will be COPD. Another half of them would be OHS or obesity hyperventilation syndrome. So at least that was clear that not anything else is playing a role. Then we took a control. We didn't just want to have this group, we wanted to have a control as to if we did nothing. And the controls were people who had the same hypercapnic respiratory failure admitted to our hospital, but not consulted. Not every patient who comes in the hospital services, they will consult pulmonary. So we identified those patients, say, let's put them as control and see what happens. Next slide, please. So here's the three groups which I wanted you to focus. Now, the green line are the patients who had severe hypercapnic recurrent respiratory failure, identified to have non-invasive ventilation needs, sent home and discharged on non-invasive ventilation, and were very compliant. How do you know compliant? Because we can download that data from those machines. And if anybody is using for more than 4 hours daily, or 70% of the time, that is the Medicaid CMS guidelines or criteria for compliance. The green line has the highest survival. Almost 100% of them survive. The red line is basically the controls. These are controls which, never were consulted, were taken care of, but had been admitted for hypercapnic. Significant number of patients died in that group. The black line in between are the ones who we identified, we saw, we said you needed non-invasive ventilation. These people were sent home on non-invasive ventilation, but didn't use it. Non-compliant. And you can see that their survival is also compromised. So the best graph part was the green one, where we identified, gave them, and these people were compliant. None of them died, and this is a whole year that we followed these patients up. So huge benefit if we identified and these patients were educated on that. Next slide, please. This is just a hazard ratio, which we calculated and look at the patients who had non-invasive ventilation and were adherent. The hazard ratio was simply very low at 0.05, suggesting a tremendous amount of benefit. Next slide, please. Here's another way of looking at it is what happened to the emergency room visit? Its readmission is great, but what about the emergency room? Maybe they went to the emergency room and not get revisit. The adherent group, which was the one which did best in the readmission, also had the lowest emergency room visit. And the non-adherent and the controls continue to have larger number of emergency room visits for cardiovascular reasons. Next slide, please. And then we dug in deeper and said, listen, we told these people, you're sick, you can die from this condition. We gave them a device. And how come some of them didn't even use that device? So we broke all of these people down and we found out again that intolerant to CPAP mask was the number one reason, which was not very surprising because not everybody can tolerate non-invasive ventilation, CPAP, and masks. And that's been documented in other studies too. What surprised us was that the second largest group of people who were non-compliant with a low health literacy. Again, we were not able to close this gap, that we were not able to explain how important this is for you. They were not able to capture the essence of why this is so important to protect them, to save their lives and stuff. So again, the same theme is emerging, that in West Virginia, we have to invest in health literacy. We have to ensure that these patients fully understand what they're dealing with. Next slide. Now, you must have seen this slide in the last few slide sets which I presented, which is basically, again, reiterating the distance, that although health literacy was a strong factor in these people being no-shows, distance did matter. was a number two reason for that. How do we tackle that? How do we, health literacy again, and how do we tackle that? Of course, it is, impractical to have millions of dollars poured into sleep labs. Strategically, probably some areas can be served, but there are a lot of huge rural swaths where it would not make sense. So we tackled that from a different perspective. Next slide. So what we decided was, we said, hey, how about we can't give them sleep labs, but what about sharing expertise with the rural physician? So we went in and we interviewed all these rural physicians and said, what do you know about it? And tell us what are the factors which really, prevent you from giving that care. To our surprise, we found that a lot of physicians, even out in the communities, felt that OSA was an important disorder and disease driving many of these other chronic conditions. But look at that. Their confidence in identifying sleep apnea was very, very low. So they acknowledged that presence, but they felt extremely limited in their ability to either diagnose or do something about it. So that was a very important lesson for us, where to focus. Next slide, please. So we thought that why not empower the rural primary care providers and teach them and then see what happens. Next slide, please. So Dr. Stansbury, along with our group, worked on this refinement of this educational program. And it was impressive enough that NIH gave us a grant, and Dr. Stansbury got a K-23 grant to address this educational gap between the expert centers and the rural community physicians. Next slide, please. And so one of the models we developed was a novel shared intervention, and there were two parts to it. One part was, we will hold a lot of lectures and didactics and closed loop sessions with these primary care physicians until they're comfortable, until they know what sleep apnea is, how to treat that. Next slide, please. And then the second part was, how do we support them beyond education? And then we came up with this plan in which we will provide them with logistical support, which means that they could order a home sleep study right where they are in the rural condition. The home sleep study would be sent to that patient. They would get the results, and they would have direct communication through the red cap to board-certified sleep physician here in Morgantown to ask and ping question, what does this mean? What should be the next step? What is the differential diagnosis if this is not correct? What are the options for these patients based on the AHI and the T90 or the amount of hypoxia, all of that? And that would be a closed loop until the patient gets the treatment. Next slide, please. So this was the implementation science behind that. So next thing we focused was, as we alluded to you, the sleep deprivation part, which was very important, and that exhibits in terms of other comorbid conditions getting worse. Next slide, please. So we launched a study called Sleep Well, Live Well. And there was a community study. It was a randomized control trial. And basically it was based that we'll take a county, and in this case, we took Harrison County as one of the rural counties, and we decided to have an intervention which is very, very cheap, and it is very doable, and it basically is designed on the fact that sleep hygiene is a known science. It is available, but the information of that to the patients in rural community is very low. Now, you could Google and get sleep hygiene tips from Google, but what we did was we basically combined all the good factors which are basically approved by the American Academy of Sleep Medicine. So the patient doesn't have to spend hours Googling. Number two, they are not exposed to some bad information, because Google, the problem is you can have good information, you can have bad information at the same time. And then what I did was that I put all of that information in a 10-minute lecture. And I delivered that lecture myself. That lecture was available to all the participants who were in that study. And all they had to do was watch that video for 10 minutes period of time, and then answer 3 questions. All these answers were embedded in that. So if you listen carefully to the lecture, you would immediately know what the answer was. And that was a cue that these patients actually did view the video. So next slide, please. This also study got published earlier this year, called the Swell study. You're more welcome to go ahead and read the details when you have time. But next slide, please. So the overall design, arching design, was in a randomized control trial. We decided to go with the intent to treat. And for those who are not familiar with that, intent to treat is that once you've decided which group you belong to, whether the intervention or non-intervention, then we just stick to that. And we stick to that until about 7 weeks period of time. And around 7th week period of time, we cross over or we open, which means that the group which did not get that intervention is now open. And if they wanted it, they can view the videos, and we still track them, total of 12 weeks. So 7 weeks, intent to treat, and then open label and see what happens. And in order for us to make it very objective, if you remember that we talked about CDC, CDC has a criteria where they send a survey. We were, as physicians, always suspect that when you ask somebody, are you really getting the answer what you want? Is it truly happening? So we wanted to have more objectivity, lent into this program. So we gave for free an Oura ring to all these patients. If you participate, you get a free Oura ring from us. What the Oura ring did was we had a system and a platform, and of course, with patients' consents, all of that information was dumped into that. So we had objective idea of when these patients are sleeping, when they are awake, how many naps they are taking. All of that good stuff was being recorded. And it was, of course, there was a survey, but this was a much more objective way of looking at it. So we randomized that. In the interest of time, I'll move on to the next slide. So the intent to treat comparison, if you look at that the first 7 weeks, you'll see that the intervention group is the red one. And in the 7-week period of time, seems like they may be sleeping a little bit better, but to our surprise and shock, it was not statistically significant than the other group, which was not randomized to it. So statistically, no difference in the 2 groups. But let's look at when we dig deeper and find out what happens to that. Next slide, please. So one of the issues what we found in the study was that despite all the elements which we tried to make easy for the patient, for example, the video was given to these patients via email. The video was not designed to be seen only at a specific time, that you can only listen to Dr. Sharma on this period of time. If you had time at work, you could listen to that. If you came back from home and you're having a cup of coffee or tea, you could look at that. If you're going to bed and you had some time. So it was open to it. But despite that, there was significant non-compliance. So then we recharted and we said, if people didn't even see the video, then how is that intervention? And so we decided to look at it from who actually saw the video and who did not see the video. So compliance versus non-compliance. So this is the results of that non versus non-compliance. And you can see that patients with red are the ones who were initially started, saw the video, and then you can see throughout the first 7 and the after one, they continue to improve their sleep. The number of hours of sleep continues to go up. The green one was the ones which initially they were randomized not to, but then after it was opened up, they decided, yes, they want to avail that opportunity. And you can see they were coming down and now they were going up in their sleep. And the blue ones at the bottom are the ones which were non-compliant. And you can see how poor their sleep, not only in the beginning was, but it continued to actually worsen. In essence, when we looked at all of these things, we found that compliance with this 10-minute of sleep hygiene video improved sleep on an average for 30 minutes. 30 minutes, which is very impressive, because if you take zolpidem and all these chemicals, it only improves your sleep by 20 to 25 minutes. Okay, that's the study. So just a simple, non-toxic, non-chemical intervention we found in a rural community could improve your sleep and sleep hygiene. Next slide, please. So basically, what we had in mind is this very elaborate structure that there's a socio-ecological factors, that sleep is not a monolith disease where you do one thing and happens. There's a lot of layers to it. And each layer has to be addressed. You know, there could be personal issues like sleep disorder breathing. There could be individual factors, mental health, biological, temperature, your surroundings, which can impact. There could be family factors, neighborhood, social, cultural. And we also realize how much health literacy, again, plays into that. So there are multiple layers to improving sleep, and that's what we were targeting in our approach and our attempt to improve sleep in West Virginia. Next slide, please. And this is the research team, and this has done all the wonderful work in the last 5 years. Now I'll be open to any questions.